Okay, good afternoon, everybody. The recording has officially started. I am Mary Franzen, the Coverage Strategies Manager at the Healthcare Authority. This is the meeting of the Finance Technical Advisory Committee. Just as I was saying a moment ago before the recording started, if you are a panelist or a member, if you are signed up for public speaking or a member of FTAC, when you have the opportunity to be a panelist, please say okay. Then you'll be able to unmute yourself and speak. The recording will be posted on the committee's webpage after the meeting. That usually takes a couple days for processing, but it will be posted publicly. And now I'll turn it over to David DiGiuseppe, the FTAC liaison to the Universal Healthcare Commission, who will call us to order.
Thank you, Mary, and welcome, members. It is now 2:01 p.m., and I call to order FTAC's May 2025 meeting. I would like to welcome everyone joining us today for the 15th FTAC meeting, believe it or not. I'll start with an overview of the agenda. We have a full agenda today, and I will begin with roll call. After roll call, we'll vote on approving the March meeting summary. Following that, we will hear public comments. After public comments, Mary Franzen from the Healthcare Authority will briefly review where we are in the 2025 work plan. Following Mary, I will provide an update from the Commission and spend some time reviewing their design progress and how we have and continue to help with that. We will take a short break after my presentation. Following that, Todd Bratton from the Healthcare Authority will update us on cost containment related to the work plan topics. Todd and Ross Valori will also provide a brief update from the Healthcare Cost Transparency Board. After these updates, Liz Argent from Health Management Associates will facilitate the FTAC discussion on next steps. And now I'll turn it over to Mary Franzen to go through roll call.
Thank you, David. I will go through, call David first, and then other folks alphabetical by first name. So David DiGiuseppe.
I am here, thank you.
All right. Christine Eibner.
Also here.
Eddie Rauser.
Present.
Esther Lucero. Ian Doyle.
Present.
Okay. Kai Young. Pam McEwen.
Here.
Robert Murray.
Here.
And Roger Gantz.
Here.
All right, thank you. And before I turn it back to David, I'm going to just take a moment to recognize the work of Todd Bratton, his hard work on behalf of FTAC. As many of you probably know, the state often has temporary positions or project-based positions. It's how we get a whole lot of really good work done. It's how we bring people into the state, and it's how Todd joined our team. Unfortunately, sometimes it also leads to moments like this as we watch those positions sunset and the project comes to an end. So this is likely to be Todd's last FTAC meeting, and I just wanted to say thank you, acknowledge what he's done. He started last August. He jumped into this subject matter with a vengeance and has worked very hard and really brought together a lot of FTAC members and gotten to know people very, very well. Also, an incredible amount of work for the Universal Healthcare Commission. So, David, I will turn it back over to you with my thanks to Todd.
Thank you, Mary. I'd like to second what you said. You know, as a recent chair of this committee, I've had the good fortune of working directly with Todd. And in addition to the heavy lifting you've done, Todd, you've been a great thought partner, and your diligence in helping not only our committee, but the commission move this important work forward has been evident. So thank you very much for that.
Thank you both.
Okay, please join me in turning to the second tab of your materials. The recording of the last meeting is posted on our webpage. We will use the consensus process for a vote on the approval of the January meeting summary. Actually, I think that's the March meeting summary. Is that right, Mary?
Yes, it should be March.
Okay, excuse me, the March meeting summary. Is there any discussion of the meeting summary or proposed changes? Okay, seeing none, I propose that minutes are accepted without change. Any discussion of this proposal? Okay, all in favor say aye.
Aye.
Any opposed? All right, we have approval by consensus. Next, we will move on to public comment. So committee members can find written public comments under tab 3 of your meeting packet. Individuals may sign up to provide public comment before the meeting, and we will hear from those who signed up now. When you are called upon, please state your name and affiliation, if any, before speaking. Members of the public who are not on the list may raise their hand and be called upon to speak. You will be moved into the panel when you are called upon, and this may take a few moments before we can hear you. We will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comment. Mary, would you please start with the names of individuals who have signed up to provide comment?
Sure, thank you. One person signed up ahead of time to provide comment, and that's Rachel Snell.
Everybody hear me?
Yes.
Okay. Hello, members of the committee. My name is Rachel Snell. We have great news here in the state of Washington. Senate Joint Memorial 8004 has been passed. Washington State is one step closer to achieving universal health care for all in this great state. This means we are also on the road to saving money for hard workers. According to an article on the Physicians of National Health Care, supporters of Medicare for All are right. Universal health care insurance through taxes would lead to a large tax cut for the vast majority of workers. Another note, I for one am sick and tired of hearing another meeting from leaders talking about how we need to cut spending when wealthy corporations and insurance companies receive never-ending tax breaks and profits year after year, all at the expense of those who they are meant to serve. Which is why we need to be calling Governor Bob Ferguson's office and demand he sign into law bills that will generate progressive revenue to fund programs like universal health care. The work for achieving universal health care for all has only started, and there's still so much work to do. Thank you so much.
Thank you for your comments. We only had one person who signed up, but we do have folks here. So if you would like to offer public comment, please put up your hand. Catherine Lewandowski's hand is up. If someone could move Catherine over, it'll take a second or two, and then she can make her comment.
Apologies, can you hear me?
Yep, you're good.
I don't really have anything prepared to say. I just want to tell everybody thank you for your work. We are super busy at Whole Washington getting ready for our gala on Saturday, so that's why I'm not prepared. But just to say, I think it's even more important now that we really, really, really look at what we can do, because the rug's about to get pulled out from under our entire health care support structure. So let's get at it. We don't have much time. All right. You guys have a great day, great weekend. And if you'd love to go to the comment or gala, I can make room for you if you'd like. You have a great day. I will be listening. Thanks.
Okay, I don't see any other hands up. We'll give it just a moment to see if anyone else wants to put up a hand to offer a comment. I don't see any more, David. I think it goes back to you.
Okay. Thank you to the two of you who provided comment today. This committee welcomes and encourages public comment and appreciates all feedback received. Public comment is an essential part of the process, as it provides an opportunity for the public to have their voice heard at regular meetings. Public comments can be provided orally at the meeting or in written form. FTAC members review and consider all public comments received and often discuss those comments with the Universal Healthcare Commission. Hopefully, it is evident that public comments are heard, as evidenced by the discussion at April's commission meeting regarding potentially accelerating the timing of governance. FTAC committee members generally will not respond to public comment during the meeting. If the committee deems it appropriate, a response will be provided in writing or at the next public meeting. Committee members, please now turn to tab 4 in your packets, and Mary will briefly remind us all where we are in the work plan.
All right, thank you. Here we go. The next slide, please. Again, always good to be grounded in where this work comes from. The RCW that established the commission, the Universal Healthcare Commission, and also the work of FTAC. So there's 2 parts to the work: immediate and impactful changes to improve the system that we have in place right now. We generally call those transitional solutions, sometimes interim solutions, and also to lay the groundwork for a universal system design that would be a system that would provide healthcare coverage and access for all Washington residents. So the next slide. Here's our tracker of where we are on various topics. We are focusing today on universal system design. That's our column to the left. We have the green, eligibility in green. The other things are in orange. Those are in progress. The transitional solutions, the work for that is ongoing. In late 2024, the Commission decided to spend the first half of 2025 focused on universal system design, and then bring back some of the work on the transitional solutions in the second half of 2025. So here we are in May. We will be getting back to the transitional solutions soon. Probably our next meeting, some of that will be on our agenda. The next slide. Today's meeting, we're hitting upon each of these orange ovals: the benefits and services, the cost containment mechanisms, and provider participation and reimbursement. Some of that is coming to us in the form of feedback from the Universal Healthcare Commission. That's a lot of what David will be talking about today. And part of that is a cost containment and a healthcare cost transparency board update for the cost containment mechanisms. So the next slide. This should be a familiar picture by now. It's us wending our way through the year and the various topics. So here we are in May, feedback on cost containment at the FTAC meeting, and again, benefits and services and provider reimbursement. That's what we were showing on the previous slide. And the last slide just looks ahead to the second half of the year. Still moving the topics through. The orange is, the first time through, and the red is coming up with the final recommendations, with some open time at the end of the year for future topics, because there will be more topics or schedules will shift as we go along. And that's the end of my work plan update.
Okay, thank you, Mary, for that update. FTAC members, please turn to tab 5 in your packets. And I want to take a moment to just recognize where we are in the process. It was about a year ago that we started talking about benefits and services. Shortly thereafter, we engaged Milliman, and some of our colleagues here, Roger and Eddie, put in significant extra time outside of these meetings, helping Milliman define the study. So I greatly appreciate that. And I think we can all celebrate. When I presented to the commission in April, the commission made some significant decisions about benefit design that I'll share with you. So I just want to pause and congratulate you all on some difficult and important work in reaching this milestone. All right, I'm going to jump into, there's one other thing I want to say too. We do have significant work to do, even getting into more detail on the benefit designs. One thing that's happening behind the scenes is we're working to put together a sub work group of FTAC members and commission members, similar to what we call the FTAC liaison group that had been working with Milliman over the past several months to define the study that they worked on. So if you have any interest in joining that, it doesn't have to be the same 3 of us. I think we have the ability to either substitute or add some new members to that work group. The point of that will be to get into more detail around benefits and services, and I'll go into what that might look like as I'm going through these slides. So I'm not sure, is it Kia who's running the slides? If you don't mind moving to the next slide, that'd be great. So, the point of this next step in today's meeting is to show you what the commission meeting looked like. So I'm going to go over what we heard, well, the agenda of the commission meeting, which was they had public comment at the beginning. They talked about the question of governance and whether governance should be accelerated as an analytical step in the process. And then we went into the cost modeling analysis. There were some open questions that came out of those, both the governance and the cost modeling, that I'm going to share back with you. And then we talked a little bit about the cost containment recommendations, which we're going to talk about more in the latter half of today's meeting. Next slide, please. So the public comment, these are the three highlights. There were comments supporting general advocacy of the proposals moving through the legislature and support for universal health care in general, with recommendations to look to the way that that's been implemented in other countries, focusing on primary care and addressing the high cost of care, high prices, and additional voicing of support to accelerate when governance is addressed in the process. And folks pointed out that the reason why that would be important is because it's a way to gain public support early for what the system might look like. And there was a request for an actuarial study about the administrative expense. Next slide, please. So then the commissioners turned their attention to this question of governance. And I think you all remember from public comments in our meeting that folks have advocated that we talk about governance now as opposed to later. And the first idea that came up is to, in contemplating what it means to talk about governance, is to distinguish the infrastructure, who administers the system, from the oversight and who regulates the system. An example of the administration of the system is the Model A versus Model B that we learned about early coming out of the Universal Healthcare Work Group, their work a couple years ago, where Model A is a single payer system and Model B is a system that relies on carriers that are in place today. An example on the oversight side is, is there a state agency that would run the system or oversee the system? And is that a new state agency or an existing state agency? And the idea was, the question was asked whether the Washington Health Benefit Exchange's governance structure provides a model that the commission could turn to as a template. Next slide, please. So then folks talked in more detail about the timing of addressing governance. And we have it today in what's called phase 3, which I think you saw on that work plan that Mary showed. And you can think of that as a bottom-up design where we work on the medical costs or the total cost of care of the system on the medical side, and then overlay administrative costs and structure later. The arguments in favor of that are that is logical. It makes sense to start at the bulk of the expenses in the system and then work up to the top there. The arguments in favor of accelerating the governance discussion is that it establishes accountability from the public's perspective sooner. I was asked whether it affects our work to accelerate governance or not, the work that we all are doing here in FTAC. And I didn't want to speak on behalf of us because we haven't had that conversation yet. I did characterize in the presentation, which you'll see excerpts of from today and that you all got a sneak preview of before I presented my report out to the commission at the April meeting, that the way we have staged it is to continue working through these big issues of medical costs, benefits and services, provider reimbursement, et cetera, and deal with the administrative piece later. So I think implicitly, the way that we're handling it is in favor of keeping the administration in phase 3. I'll tell you personally, for me, that's logical and that makes sense. And I think it's appropriate the way we're progressing through it, but I'll re-raise this question for you on the next slide when I get through a couple more points. So Key, if you could please go to the next slide. So the commission decided that rather than make a decision at the April meeting, they're going to bring it back to the June meeting. And our colleagues from the Healthcare Authority are going to bring some additional information to help inform that discussion. So in the meantime, I thought it would be helpful for us to discuss and see if anyone has a strong opinion about it being beneficial to accelerate that discussion as opposed to the way that we're progressing through it now. And then I could represent that at the June commission meeting. So I'm going to stop there on this purple question and ask if any of you have opinions or ideas you want to discuss about accelerating the governance question.
Acceleration, does that mean more meetings sooner? Or what is the accelerated component refer to?
Yeah, that's a good question. My interpretation is that we take our direction from the commission. So first, the commission would have to say, yes, we agree it's important to accelerate. I think, and Mary, you probably know better than I do, that they would then have to dictate a change to the work plan, and that would cause us to use time at our July, presumably, meeting to talk about governance and the finance and technical issues associated with governance, and that would bump other issues. Is that your understanding, Mary?
Yes, that's correct. I think it would shuffle the order of the, if you think, Eddie, of the picture with all the ovals, I think we would be moving ovals around.
Okay.
Mary, am I calling on people or are you calling on people? I can't remember.
Oh, either way's fine.
Okay.
Pam.
Yeah. Hi, thanks. I'm happy to have a chance to comment on this because I know we had some discussion earlier and I felt some empathy or sympathy or understanding of why some of the advocate groups would be bringing this up. I think there's some real merits to doing governance early on. But I think that the downside for us outweighs that because this is an environment in which it's tough to make decisions. We're deciding between two groups, going back and forth. And I feel that reshuffling, it's just not a matter of just moving ovals around. There's a lot of things that get moved around, and that will slow us down. And I think that unless we feel like there's a real problem, my preference would be to urge, the Universal Healthcare Commission to stick with the plan that they put into place that took them a lot of effort to draft up and come to a conclusion to support.
Thank you, Pam. I appreciate that, especially recognizing the reasonability of wanting to accelerate it and just the practical aspects that you pointed out.
Mm-hmm.
Roger?
Yes, thank you. I want to re-clarify, if I might, and David, I think you did a great job of it, the notion of the administration, let's say, of the system versus governance, because I think in my listening to the commission, those two concepts got somewhat confused and folks were kind of seeking clarification. And I felt Jane Barr did a nice job of doing that in the context of saying when one thinks of administration of the delivery system, and David, you used a good example of the model A and B that came out of the work group, i.e. do we have carriers or not, et cetera, versus governance in the context of who is administering this entity, the board structure, et cetera. And I felt that after some degree of discussion, the commission members kind of came to an agreement that no, they're not talking about administration as we might use it, but the governance of it, that is the governance of the whole system, board structure, et cetera. I guess my view, I might share Pam's concern about workload and timing. The question I guess I would pose on governance, is that necessarily something that the commission would look to us being FTAC to deal with, or is that something they unto themselves with staff could deal with? Because when I think of governance, I think, again, examples would be we have a 9-member board. There's the composition of the board. Here's the board responsibilities, et cetera, et cetera. And while I think I look at our FTech group as being, having expertise, I'm not sure we have any more expertise in that area than any other group would have necessarily, or that staff would have by putting together a series of models for the commission to look at, and not needing necessarily our group to weigh in or draw time to that topic. So I guess what I'm trying to say is I'm somewhat ambivalent. My ambivalence is to say I think that governance can go down a separate path while we continue our own work, and not necessarily needing FTAC's expertise or involvement in.
That's a great point, Roger. If you think about our name, Finance Technical Advisory Committee, some of us fall more on the finance side. I think some of you have experience on the technical side, like setting up regulatory bodies or working with regulatory bodies. I can certainly characterize that distinction back, Roger, and maybe if you want to voice it, anyone wants to voice it now, or maybe message me offline if you feel like you have expertise on the regulatory composition side. That would be helpful, because then I can represent to the commission whether we as a group think we could be helpful in that realm versus not being helpful there.
Yeah, I'll say one more time again. I'm talking just about this area of governance. There's been a variety of groups, including our own, as Pam can relate to in the past, our own Healthcare Commission, 1990, get my dates right here again, 1993, Pam, the right date, where there's a governance board structured for that. I mean, that was one to look at. Oregon has recently passed enabling legislation where they lay out their governance board, where it sits in the organization, and here's what that board looks like. So I guess my take on that is I think there's a lot of work that's been done out there already by other entities. And I think the challenge would be, quite frankly, is just to assemble that information. Here's model A, B, and C, and D. And folks, what do you think about it?
Understood. Yeah, I think it's a great point, Roger. Bob.
A couple of things. Roger, what's your understanding of the governance board in Oregon? What are they? They're not doing a universal healthcare drive like,
or they
are they?
Yeah,
okay.
Yeah,
is there legislation that?
Yeah, they passed enabling legislation. They have the Oregon Health. I can't remember the title. It's a board. So
Yeah, okay.
I believe it's 9 members. It sits in their Department of Commerce, which is interesting because Department of Commerce includes what would be equivalent to, in our state, to the Office of the Insurance Commissioner. So essentially, it kind of sits with where our state's Office of Insurance Commissioners. And that's where that board sits today. They're responsible to go through, another kind of redesign exercise. But I'm just repeating again, the governance of that board, the who's who, et cetera, is laid out.
Yeah,
And-
okay. That's all. I just wasn't sure
Sorry.
what the context was
Yeah,
in
sorry.
Oregon. With regard to David, I forgot that way you phrased it, but something about expertise about governance design or whatever.
Yeah.
I do have a fair amount of experience with that, just having worked at a regulatory commission and fully understanding the legislative authority that commission had and the oversight. So I don't know if people are interested in that, I'm happy to discuss it here or with the Universal Healthcare Commission if it gets to that point. I mean, obviously it depends on what the strategy is and the timing and everything, but I just wanted to volunteer talking to folks and sharing some of my experience in that regard.
That's great, Bob. Thank you. I think, I'll give other folks a chance to chime in too, but where I'm at right now is I think we could represent, or I could represent to the commission where we are as FTAC, is that we would advocate keeping governance in phase 3. We think that the commission's work around the regulatory structure is more commission work rather than FTAC work, but that, Bob, you would be available to talk to the commission about your experience rather than us debating it here. Let me just pause. Does that sound good to everybody? Does anybody have a different perspective? Okay. If you think of something later that didn't occur to you and you want to talk about it, just send me a note and we can add your thoughts in, or I can add your thoughts in. Can you please move to the next slide? Okay, so just retracing our steps a little bit. You may remember coming out of our March meeting, we put together a set of slides that I would present to the commission to summarize the Milliman study. So hopefully you all either had a chance to look at that or if not, if so, potentially provide feedback on that, which we incorporated into that. Largely, the way I characterized it was that Milliman work was our round one, and I was presenting additional work that could be done that we had organized in various steps, and I refer to that as round two and round three. Peter from Milliman was alongside me in the presentation, so he was there to answer questions. We got a lot of insightful questions, and then Liz did a fantastic job of facilitating a discussion along the way. And it was a great, as I mentioned earlier, just a great experience to be part of because the commission was making decisions on some of these key things. And as I mentioned, there were some open questions left. So what I'm going to do on the next few slides is I'm going to show you for each of the big categories presented, benefits and services, eligibility, provider reimbursement, the key slide that was in the deck that we all worked on that I presented and the questions that we gave to the commission. Then I'll show you the decisions that the commission made and any open questions that were left. And one of the things that I've done on that slide is to what I call stakes in the ground, to say, here is a starting point for how we would recommend the commission answer the open questions. And I'm purposely putting a stake in the ground so that you have something concrete to react to. So if you disagree with what you see there, I want you to argue the point. I've just found that because we have so little time in these meetings, the discussion is more efficient if we anchor to a starting point. It helps elicit stronger agreement or disagreement, faster discussion, and we move on. So let's see how this works. If you don't like the process, the whole stake in the ground thing, let me know after the meeting, and I won't use that again in the future. So, Kia, if you could please go to the next slide. Yeah, this is an important point. So, the way that we constructed the deck that was that I presented to the commission was we're bucketing subsequent analyses into phase 2 and phase 3 with the idea that Milliman would help us with those. The reality is, under the current state budget situation, we are unlikely to have any additional funding at our disposal to have Milliman participate in doing these analyses. So I think what that means, ultimately, we're going to have to rely on the information that we have and the expertise in this room to help the commission figure out how to work through these remaining questions. The second bullet here is just referring to that subgroup that I mentioned before, where because this is so complicated, because there are nuances to the decisions that the commission made, we came up with this idea of having this off-system work group where we can work with select members of the commission, select members of our group to get through some of these questions. And I'll say a little bit more about that in the next few slides. Roger.
Yes, thanks, David. While I wholeheartedly agree with your comment about the availability of funds, and we know what's in the in the government, in the House and Senate budget for the commission, this work in 2025 and 27. And I'd be the first to say it's something in the order of about half of what the commission had to work with in the 23-25 session. So I concur with the notion of a major concern about available funds. However, I would like, as we go through this, to consider some of a notion of conceivably developing a detailed sort of a proposal for phase 2 and or 3, that we have some effort to try to cost that out, and that the royal we, be it the Healthcare Authority or ourselves and others, give serious consideration of going after new money from the legislature in 2026. And I say that because, in my opinion, to do the work that we need to do in the benefit design area, we cannot do that without Milliman's work. So to try to, manipulate the analysis that we have to date, I don't believe we can do that. We are going to need more analysis to do that. So I guess what I'm trying to say back, David, is a suggestion that as we go through these questions, et cetera, is not be hindered by resource constraints to begin with the notion, again, of coming back conceivably with a design, a proposal to go after new money.
Understood, Roger. I think that's a great point. I will confess I have a higher tolerance for using the existing information and making inferences and estimates. And I think we have a lot of information. There's a lot we can do, but I appreciate what you're saying, and I think there's nothing. I think what you're describing is logical and prudent. Let me say that, if we have the funds available, or if we can advocate for the funding. Anybody else want to react to what Roger said?
I think Eddie, Roger was saying about a parking lot of items that we keep track of that won't have a resource constraint, but an opportunity to get funding later. It's a good idea.
Yeah. Okay, that's great. Thank you for that thought, Roger. Okay, next slide, please. So this is one of the slides that you hopefully saw before, starting with benefits and services. This was presented back in April to the commission. So you can see on the left, we came up with a series of questions, and then we provided a recommendation of how the commission could answer these questions. So basically the questions were saying, are there any benefit design, service coverage options that we didn't study? So if you recall, we studied the Medicaid covered services and cost sharing, PEB/CEB covered services and cost sharing, and then Cascade Select Silver. The recommendation was that if the commission can articulate additional options, we would incorporate those. And similar to what Roger was saying before, we were advocating for some additional money for Milliman to create what we've been thinking of as an economic model. If you remember the study that we did with Milliman, we've been thinking of that as a sizing exercise based on historical data. A more, true economic model would project the years forward, account for some changes and trends and service coverage and other things that have happened since that historical period in time. If you go to the next slide, please. So you'll see here at the top, these are the decisions that the commission voiced, and then in the middle are the open questions, and then that bottom section is what I was referring to as the stakes in the ground. So the commission did not advocate or ask for any benefit designs outside of the 3 that we modeled in that baseline assessment. They did say that they wanted to aim for the PEB/CEB. We were calling that scenario 2. So scenario 1 was Medicaid services and cost sharing. Scenario 2 was PEB/CEB, and scenario 3 was Cascade Select Silver. So they zeroed in on PEB/CEB, and there was a desire to aspire to Medicaid coverage and cost sharing, which is zero cost sharing, but a recognition that that's cost prohibitive at this point in time. There was comment about retaining scenario 3. So that's, again, the Cascade Silver design. And the point there was that if you think back to the Milliman results, that design was basically cost neutral relative to the current amount of money in the system. So folks were saying, don't lose sight of the fact that if we wanted to convert to a universal system at no additional cost, that's what the world would look like. And they are advocating to not stay there, but to go to the scenario 2 PEBSEB design. There was also an expression asking that vision be included and that we as FTAC help consider adding into the design at a more detailed level whether you could have higher cost sharing for more expensive procedures. So a couple of things happened after the meeting. So I'll start with the open questions here. These are two sides of the same coin. So one of the things that we did in the baseline modeling was we said anyone who qualifies for Medicaid, so anyone who's low income, would continue to enjoy Medicaid covered services and zero cost sharing, whether it's scenario 1, scenario 2, or scenario 3. And the question that was not addressed is, would that persist if the state adopted a PEBSEB design? Would that assumption hold, or would every beneficiary in the system experience PEBSEB covered services and PEBSEB covered cost sharing? And Roger put together a fantastic array of tables that help articulate these questions in more detail and break down across the different scenarios what's happening in each eligibility segment: the Medicaid folks, the folks who are uninsured and then come over into the insured side, the folks who are individually insured, et cetera. And so what I've conceived of so far is that those would serve as the basis for the discussion in this work group of a select group of us and a select group of commissioners to get into details to ultimately help the commission understand those nuances. So I'm purposely not teeing up Roger's work in this conversation because I think it would take quite a while to work through that. But I think what you did, Roger, was fantastic and will serve that work group well and be the starting point for that work group. So getting to these stakes in the sand and answering these questions, these outstanding questions, I think it's really important that we keep in mind a point that, Roger, you've been reminding us of, is there are covered services and there are cost sharing levels, and those are two different characteristics that we need to think about individually. And what I'm proposing here is that we think about, on the covered services side, that PEBSEB, which are the essential health benefits for the state of Washington, be the basis for all populations, including folks who are eligible for Medicaid. And it should be said that LTSS, long-term supports and services, are carved out of this discussion. This is not saying that LTSS would go away. And I think one of you helped me understand that vision is already covered. So even though one of the commissioners asked about that, vision would stay. Vision is already accounted for. On the cost sharing side, the stake I'm putting in the ground is that those folks who would qualify for Medicaid under 130% of the federal poverty level would continue to experience zero cost sharing. The last bullet is just saying, I think coinsurance addresses that last point that was raised at the commission about higher cost sharing for more expensive services. If you have a 20% coinsurance, naturally you pay more for a higher cost service. I'm not sure if that fully meets the spirit of what the commissioner was asking, but I think it gets there. And my point is, as long as the PEBSEB design has coinsurance on radiology services, that would take care of it by itself. Okay, I want to stop there and let you all react to, do you agree with taking these recommendations back to the commission or not? Christine.
Yeah, I just wanted to make a comment about the higher cost sharing for more expensive procedures.
Yes.
So I'm not sure how I feel about that because, well, first of all, the more expensive procedures may tend to be things that people have more need for. It's more urgent, or more important for their health. But also because just the way that works, I guess, economically is that in order to achieve the same sort of state savings to the government, if it's a more expensive procedure that, and I'm assuming that's also the less common one, then you have to put more cost sharing for a smaller number of people who are sicker, versus if you just increase cost sharing for something relatively common like a acute care visit or something, then it's a smaller increase that you need because it's spread out across a larger number of people.
Yep.
So I just wonder about that. It just strikes me as maybe something that would disadvantage people who are the sickest.
I think that's a great point. I think the commissioners would appreciate that perspective. Yeah, thank you. Eddie.
Yeah, so I do know that I guess the recommendation was to get rid of our third option, but from all the work that we've done so far, it seems like we should just keep it tagging along as just an anchor. I don't know if it's just part of the structure of how they want to only present two versus having three, but it seems like we have a lot of work done already with that in the mix. So
yeah,
it's tough to see it go. Because it can play off the other two.
Well, and when I hear you talking, Eddie, I think that was the intent of the comments made by the commissioners. So what I'm hearing you say is the same thing I heard the commissioners say. Okay. So that might be my failure in explaining it properly.
Okay,
here.
Got it.
Roger?
Yeah, can I jump into that last point for just a moment? Because I agree with Eddie. I think what we were hearing from the commission was two things in the discussion around Cascade. One was where they got themselves confused, as we tend to do, about benefit coverage versus cost sharing. And it seemed to me what I was hearing, from the commissioners, that a 68% actuarial value was too high a cost sharing burden. And that's what they saw in Cascade Silver, because that's essentially what that design is. And I heard some of the commission members say that they didn't want to see necessarily a rollback in services. Let me be a little more clear what I mean by that, because I think David was suggesting that, of seeing that the Washington's essential health benefits are not as comprehensive as PEB-SEB. So, in fact, in your slide's kind of an error. We shouldn't say PEB-SEB is essential health benefits. It's broader. It's more. And that the commission felt that in this design, I thought saying is that they wanted to keep a more robust benefit design than would be the essential health benefits. And a good anchor point for that was PEB-SEB. I want to come back and Eddie's comment. I'm wandering here. I don't mean to do this. What I thought I heard wisely was to take Cascade Silver, and the term was used was kind of as a reference benefit. As we do analysis in the future, what does it look like against kind of a baseline coverage? And they wanted to keep that in the discussion as a reference benefit, not as a necessarily design for the new system. I'm going to add one other thing in here. I'm trying to do this. The one trouble that we've had with our analysis to date with Cascade Silver as a reference benefit, I hate to do this, is that we've complicated it because for people at or below 138% of the federal poverty level, in the Milliman analysis, they did not use the essential health benefits. They put everybody into a Medicaid bucket. So what everybody's been seeing is a hybrid. And my recommendation would be, under keeping Cascade as a reference benefit design, is treat it as it truly is. By that, I mean whatever the cost sharing is, and everybody in that has the same benefit design. Not carving out or treating separately those below 138%. Because that gives you what the true reference benefit design looks like.
Yep, I hear you, Roger.
Okay, so that's a little bit in the minutia, but I think it's I agree with Eddie keeping it as a reference, and I would suggest in the analysis we do an adjustment so it's really the true reference benefit design that it is.
Yeah, I think that's a good point. I'm just taking a note here.
Yeah. Well, I had back on one other thing, because go back to Christine's. You know, I felt like we had in our discussions on cost sharing, the commission asked of us to take a look at cost sharing. We have had several discussions on it. We went back to the commission with a set of guiding principles. I don't have them right in front of me, guiding principles that came from us. And those were shared with the commission. And if memory serves me correctly, I believe the commission adopted, if you will, the quote unquote guiding principles. But those guiding principles didn't lay out specific specific cost sharing designs. So I'm moved by Christina's comments because I think some of our guiding principles spoke to some of the concerns that she very much is raising. And in the cost sharing analysis that was done to date, we haven't really incorporated those guiding principles into designs.
Yeah, well said, Roger. I got you. That makes sense.
Okay.
Yep. Okay, I want to, since I'm going to be the one who's representing back to the commission the voice of FTAC, as a consensus voice, I'm going to be fairly deliberate about this and just go around the table to make sure you all agree or have a chance to voice disagreement with what's in that stakes in the ground section. So, Pam, if you don't mind, I'll start with you. Are you okay with how this is written, or would you want to change any of this? And you're on mute.
I just said what I said was I'm kind of looking at, I think I am okay with this. I appreciate what Roger said about our principles, because I think there's a tendency when we talk about cost sharing to want to go back to these programs in which somebody's in Medicaid or somebody's a state employee or somebody's in Cascade Care. But under a universal system, everybody's supposed to be doing the same thing. So we're going to need to think differently about people's income and whether or not there's, we draw a line below which people below a certain point wouldn't pay cost sharing. And it would be, that's new territory. So I just want to call that out, but I'm fine with what's written here.
Okay. Thank you, Pam. Ian, you're next on my screen. Can you talk about any thoughts you have on this?
I just don't feel super educated on the topic to begin with. It's kind of outside my scope of expertise. I don't feel strongly one way.
Okay. That's great. Thank you for chiming in. Bob, how about you?
Yeah, like Ian, I'm not super educated on the topic. My bias is focused on cost containment first.
Yeah.
So I'm fine with the language, but it's in my mind a little bit moot until the commission, FTAC, other entities really start to get focused on cost containment and hard and fast recommendations to contain costs. So
well
said that before. I'll keep saying it.
Yeah, please keep saying it. Eddie, how are you feeling about it?
Bob's not familiar. The last bullet, I think we talked about that, where this is the first time I've actually seen that one. The higher cost sharing for more expensive procedures sounds tough. And the first bullet, the no new benefit design. So I don't know if Roger's going to have some thoughts on that. And then we were just talking about the three benefit designs. So I don't know where I'm at here.
Okay. And I should say that, I acknowledge the correction. So I'm going to pull that essential health benefit parenthetical statement out for the reason that Roger described. I think the bottom coinsurance bucket is just factually accurate, independent of any benefit design specifically. But Christine, I would add the point you made into the report out and the comments to the commission.
Yeah, it seems like it's trying to solve a problem that that may be a solution to one thing, but in that context.
Yeah. Okay. Thank you, Eddie. Christine, you're next.
Yeah, I agree with that, especially appreciate that you calling out that point that I made earlier. I guess one more thing I would say about this coinsurance thing at the bottom.
Yeah.
I mean, we know with Medicare, like traditional Medicare, there is this problem that the coinsurance is not capped, and then that leads to some circumstances where people can face really significant, annual expenditures. I don't know if the cost sharing would be high enough here to lead to that, but I think it's worth considering whether something like that could, further disadvantage somebody with extreme spending.
Yeah, that's a great point. I'm assuming PEB/SEB has a out-of-pocket max, but I'm not into that. Is that what you're talking about? Basically, it's an out-of-pocket max.
Yeah, but then I hadn't thought about the PEB/SEB connection. You're right, it probably does, and that would alleviate that concern.
Okay, Roger, I think you're the last rostered FTAC member, so you get the last word on this.
Okay, so David, let me hear what I'm under services. So let me try myself again. We started out with 3 buckets: Medicaid, SEB-PEB, Cascade Silver. My view again was, I believe what I heard from the commission was not to continue with Cascade Silver for a variety of reasons, but to consider it as a reference benefit in the analysis, which I would advocate for.
Yep.
Which is a little different. When I'm hearing you say PEB/SEB, you are suggesting that of the 2 remaining benefit designs, that is Medicaid and PEB/SEB, that we delete Medicaid and focus on PEB/SEB. Is that what you're suggesting?
That's what I'm suggesting, yes.
Okay. So I am not uncomfortable with that. I'm sorry. I'm not uncomfortable with it. And part of it is a little bit of ignorance on all of our part. And I wish that we could have got from Milliman is a comparison of Medicaid versus PEB/SEB. And I'm going to leave aside long-term care and all of those other unique things that are Medicaid. Strip those out.
Yep.
What are the material differences? I believe there are some. As knowledgeable as I am about Medicaid, I'm not quite sure what the differences are. But that being said, I'll tell you why, I am comfortable with staying with PEB/SEB as the basis. But I want to add a piece to that, is that for at least Medicaid beneficiaries, I'm not talking about low income, I'm talking about folks in Medicaid, that they continue to get otherwise what they would get under Medicaid, and that includes long-term care, but it's handled as a completely supplemental benefit.
Yep.
So we have a standardized benefit for everybody. Let me keep on with this for everybody in the state, that the state will offer to all its residents.
Yeah.
There's a group of folks that are Medicaid and they get supplemental coverage, whatever that looks like, separately handled outside of our system. Also, under this notion of a standardized benefit is of individuals, if there are services that aren't covered, that individuals in this new system have an opportunity, they can either purchase those through a supplemental coverage that they pay for themselves, okay?
Yep.
Or they just pay for them out of pocket. And I always want to use the word, I don't know, cosmetic surgery. I wish I could think of a better one than that to use. But if they want to have cosmetic surgery, they can pay for it out of pocket, or they have a supplemental insurance policy out of somewhere in the private sector that they can get those services that aren't in our standardized benefit design.
Yeah, that makes sense.
Okay, so with those caveats, I'm cool on that one. Sorry for the long one. And as you say, vision and hearing already in UMP PEB/SEB. So I'd say we take that out because it's in there already.
Okay. Thank you, Roger.
Yeah. Now on cost sharing, I believe that it's my own values that at some income level, 138% is what we're using now. For the ACA, they provide, subsidized cost sharing up to 250%. There's no magic in any of those, but the underlying concept is that at some income level, appreciable point of service cost sharing is not a burden for low income persons. 138% is good for Mark, or somebody else said I want 200%. I'd be more comfortable with that personally. But the point is that low income persons, however you end up defining it, do not have cost sharing. And the one on coinsurance, I personally at this juncture am opposed to that. I think we need to think more fully about point of service cost sharing and what types we use. Is it co-payments? Is it deductibles? Is it coinsurance? So you've kind of emphasized coinsurance in particular. I'm not necessarily endorse that myself. It's not to say we don't have cost sharing. It's just I'm not enamored with coinsurance.
Got it. Thank you. Yeah, let me. I think that was very well said. Let me just clarify a couple of things. The commission decided for us to go with PEB/CEB, and what we're doing here is to say, okay, decision heard. There are some nuances. So when we break apart services and cost sharing, I'm not proposing to refute the decision to go with PEB/CEB services, but because of the way we modeled scenarios 1, 2, and 3 with Medicaid or newly Medicaid beneficiaries having reduced cost sharing, I think it's important for the commission to fully understand that nuance. And it sounds like we're all comfortable with the 138, possibly even raising it to 200. I think that gets into that upper bullet of the commission's aiming for scenario 2 and aspiring for scenario 1, where cost sharing would be eliminated for everybody. I also take your point well on the coinsurance. I was simply stating that in the abstract, that coinsurance has the effect of making the patient pay more for a higher cost service without endorsing whether coinsurance is applied or not. What I was thinking is the commission has essentially adopted the PEB/CEB cost sharing. Now, in reality, there was no discussion of cost sharing. We're just saying PEB/CEB benefit design, which to me, benefit design is the marriage of the services and the marriage of the cost sharing. But there's no reason why somebody couldn't come in and say, well, you can achieve the same actuarial value and change co-payments and cost sharing, deductibles, et cetera.
David, I want to push back. I think that the commission, who knows what the commission, I think they were comfortable with PEB/CEB as a good, robust benefit design services that they would like, in this ideal world to have offered as the standard benefit design for Washington's residents. I do not believe there was an endorsement of the PEB/CEB cost sharing. I do not believe that's the case. I know some commissioners we know, like Vicky, would say not at all. They haven't had that discussion on cost sharing. So I guess my pleading here is to not include that one on coinsurance, and an acknowledgement that the commission was comfortable with the benefit design services, but they were moot on PEB/CEB cost sharing.
Yeah, I think that's a fair point, Roger. I think once you settle on the actuarial value of the total benefits, it becomes another exercise to get into how do you distribute the cost sharing to achieve that actuarial value.
Yeah. And I'm not sure 87% of you, I don't know if that registered with all the folks even. I know it does with Jane and, with David, obviously, they know this stuff, but I just, I want us to.
Yeah. It's just, if when we present, it costs, $4 billion or whatever to go from scenario 3 to scenario 2.
Yeah.
If they say, okay, that feels right, you're basically backing yourself into a corner on actuarial value. If you're saying, hey, I'm willing to spend $4 billion, but not $8 billion. So your point is well taken. I hope you hear that I'm hearing you. Pam? can you say your comment?
Yeah, David, and Roger, I'm responding to your comments too. I suggest we take them at their word. If they say that that's the benefits, and then for two reasons. One is that David can go back and clarify that with them. And then secondly, I had PEB benefits for many, many years, and they have as many kinds of cost sharing as you can imagine because they're two different programs. And within those programs, you can choose. People have, family members on them. They have a retirement. There's everything. There's, I don't even think I could count the kinds of, and I'm not sure that the commission is aware of that, but I don't think you can say I'm adopting PEB-SEB cost sharing because there's so many different levels of PEB-SEB cost sharing right now.
Thank you, Pam. Liz?
I was just going to agree with what I've heard the commission say is exactly what Pam and I think Roger were saying, that they agree with just the benefits and the order in which they're doing this, or which we've decided to proceed here, which they've decided to proceed is to say we like these benefits of PEB-SEB. We also then want to look at other factors that will impact how much the whole thing costs in the end anyway. For example, as Bob brought up, the cost containment. They would like to have some opinion about how the system is designed and how they might buy value in a different way, so that come up with that whole cost and then take into consideration the principles that they talked about with cost sharing, which would have that sort of graded level, but they want to do that at the end. That's the sense I've gotten from them.
Okay. So how about if I change that last bullet to say something about cost sharing design is TBD, and we're recommending following the original principles to guide that design. All right. Well, if I got a thumbs up from Roger, I know I'm good.
All right.
All right, Mary, hopefully you or one of your colleagues capture that because I'm not taking notes at this exact moment.
Yep.
How are we doing on time? Do I have time to go through the remaining slides?
Yeah.
Okay. All right, can we go to the next slide, please? So we talked about eligibility, so exactly who is in and who is out. And you may remember this slide where Milliman did modeling on pulling in the fully insured ERISA folks versus not, and what kind of cost that would add to the system. We also had discussed some of the populations that may actually have coverage today, but benefit from having additional coverage under the universal design. So let's see, you see our recommendation here. Can you go to the next slide, please? So the commission, I think, was fairly definitive in saying they want us to consider the ERISA fully insured population as part of the included population. And to think about these additional, like the VA population, folks who are covered by the Indian Health Service, supplemental coverage for those folks to be considered in a future round, not try to incorporate that in an initial, first phase transition to a unified system. So you can see down here what I'm describing is that if we include the ERISA fully insured population, that affects the modeling that Milliman did for us. So you remember they took the fee schedules from the included populations, and the ERISA fully insured group was not in our baseline. So adding those folks in renormalizes the fee schedule to a higher level. So that's just something we need to be cognizant of. If we are going to engage in additional analysis, that's something that we'll factor in. I think, Roger, you had some concerns about this commission decision. I'm guessing that may be why you put your hand up. So why don't you go ahead and voice your thoughts?
I'm sorry. Yeah, let me make one comment on ERISA. And it applies to me too. I continue to feel that folks are confused. When we talk about ERISA, there's two buckets. There's those that are where they're self-insured, i.e. it's an ERISA benefit. The employer is at risk for the benefit. They hire an ASO to administer the program. It's like for state employees, it's like UMP. There's also ERISA where it's a covered benefit, but it's provided through a health carrier, and the health carrier is the risk-bearing entity. Now, both of these are ERISA. And I'm not sure that folks always can fully appreciate the distinction there. There are some distinctions there, but they are all ERISA. Let me keep on with my notes here, but I think.
Hey, Roger, just so ERISA fully insured is designed to capture the carrier covered group. Is that how you're reading this? I wrote
no. When I see this, it kind of, I don't know. It's not clear to me. Let me back up.
Yeah.
It's not clear to
So
me.
I'll just say I wrote this, and when I use the word fully insured, I'm referring to the carrier covered ERISA group, not the self-insured ERISA covered group.
Okay. Well, okay. But let me try this a little differently. A decision was made a long time ago, and I think through the work that we help guide the commission on, is that there's two groups that if a state wanted to try to go forward with a health reform initiative that they cannot, well, it's more than two, but two huge groups that they cannot get their hands on today. One is ERISA, and we've had these conversations time again. You can't get ERISA, and it has no bearing on it being a carrier ERISA plan or self-insured. You can't touch ERISA because of ERISA preemption, excuse me. The other group you can't touch is Medicare.
Yes, understood.
Okay, so if somebody said to me, well, maybe in the modeling we should bring in ERISA, then I'm saying, yeah, in the grand scheme of things, we should bring in ERISA and we should bring in Medicare. Because if we were doing the grand model, we want them all, right?
Well, I thought that we asked Milliman to do a sensitivity analysis with the ERISA fully insured because there was some mechanism by which it might be possible to bring the fully insured in, even if the self-insured.
I don't believe that. I do not think that's correct.
Does anybody else remember? We had an expert from Maine or somewhere come and talk to us about 2 years ago. Does anybody remember that conversation? Well, I suppose what I could report back at this point in time is, if there are constraints and limitations, that's just not possible.
Well, let me try some more time. I'll shut up. It seems to me that we can have this little piece. We have the fight. I forgot the woman's name. She's back east, and James. It's always the one about what about ERISA that's in the carrier stuff. I believe if it's ERISA, it's ERISA. You can't touch it. And if somebody thinks they could, they're going to get sued tomorrow. That's also what they said. Mine would be is to say, what can we safely touch today and model that? And if you want to see the grand thing, we bring in ERISA and we bring in Medicare.
Yeah, I think that's.
So I go back to the commission, and then there's these other. I'm sorry, I keep going. The other ones that, well, what about federal employees? What about veterans?
Yeah, do you mind if because just so I gotta get through some more. I feel like I hear you, Roger, and I think the simple fix is to say, if in fact the state has some authority over ERISA fully insured, yes, we'll bring it into the modeling. If not, it's an easy closed book.
Sure.
That's sufficient?
Sure.
Okay. I don't think we need as much discussion on this as we did on benefits and services, because we're not really recommending anything other than, hey, if we get some additional money and we're able to do this, we will incorporate studying the fully insured. Please raise your hand or chime in now if you want us as a group to have any more discussion on this before we move on.
Can I add one other thing, David? I promise. One of the discussions that comes up often in these is, what about persons who are not residents of the state but work in the state? And this was a great discussion that our friends in Oregon wrestled with. And their conclusion in their task force was to not include these persons. So in other words, to be one of the qualifying events, if you will, to get coverage in this system we're talking about, is you have to be a resident.
Yeah, it's a good question, Roger. I'd have to go back to the Millman study and see how we handled that in the original eligibility. I can't remember if we addressed that or not.
I believe we did not.
Okay.
But
I mean, ultimately, it's the commission's call on that. We would have costed it out or not.
Sure.
So were those folks not considered as part of the uninsured in what Milliman did?
I believe they were not.
Okay.
I believe they were not.
I'll see if I can clarify that.
Okay. But I'm just trying to go back as a guiding principle that we may want to share back with the commission, because we got a bunch of this stuff out there that a decision hasn't been made on. And I get that. We'll continue to work on that. But as a principle, I would offer us to consider that one of the requirements for this new system is residency. Leave aside citizenship. I don't want to touch that one today. Just residency is a required requirement.
Yeah, I think that would be a perfect topic for work group. So I'm writing these down so we can tee those up. Okay. I'm feeling a little pressed for time, although I may not be. We can circle back on this if anybody wants to revisit this. Let's go to the next slide, please. Okay, so provider reimbursement. You may recall that when Milliman did their modeling, they said when you take all these markets, bring them into a unified market, weight all their fee schedules together, that equates to 125% of Medicare. Milliman modeled minus 6 percentage points of that, plus 6 percentage points of that. So that's the 119 and the 131 that you see. And they created some dollar estimates of if you drop reimbursement or raise reimbursement. They also put in the 160% of Medicare, which is the benchmark that Cascade Select uses as one of the affordability requirements. So we I presented this, posed the questions and recommendations you see here. So let's go ahead and go to the next slide. So the commission did not ask us to model any additional reimbursement rates beyond those that were modeled in that first Milliman analysis. They did ask that at the time the discussion happened, it was looking like Senate Bill 5083 would pass. It in fact did pass. So the commission was saying, look, let's at least any future modeling incorporate this notion that from moving forward, PEB/CEB reimbursement will be capped at 200% of Medicare. I'm not exactly sure how that works, given that the current Milliman pricing is at 125% of Medicare, but there may be some dynamics on capping the facilities before Milliman normalizes versus after that we'd have to think about. These next 2 points probably warrant the most discussion. So the third bullet point you see at the top there in blue is the commission said they do want to look at paying disproportionately more for primary care than the normalized average. And one of the commissioners asked about crowding out. So the idea there was if the initial version of a unified system is not the entire healthcare market, we're going to have a situation where ERISA-based carriers ERISA-based plans outside the system are going to be reimbursing at something higher, say 200%, 250% of Medicare, while providers serving patients inside the system are getting paid at 125% of Medicare. And will that lead to appointment slots being differentially favored toward folks who are covered under the market that's not in the system? not in the unified system. And I think that was a valid point, and some of you may have some ideas about that. So coming out, it seemed like the open questions were, how do we design primary care? And I think Liz put in the chat that not only primary care should get paid higher, as the commission asked, but one of the bills pays behavioral health higher. There's a question of rural health centers who get paid higher today. And I repeated the question about crowding out here. So before the stakes in the ground, Christine, let's go to your question.
Yeah, I just, in terms of that, the crowding out, I would wonder what the market dynamics would be, but it seems to me that like the ERISA plan would have a lot of leverage to negotiate down to the 125%, because they could always say they'll just drop their plan and drop their people into the market. So I don't know. I mean, I guess my gut is that maybe, but I'm not really sure. That's just my first reaction.
Yeah, that's a great point. I hadn't thought about that.
David, a quick add to the crowd out in supporting Christine's is, you have ERISA, but I'm going back there also. You have Medicare, 25%.
Right.
The system we're talking about is above Medicare. So if there's, if there's it's horrible to say, but if there's a crowd out effect, you can make an argument that it's going to be more felt by Medicare beneficiaries than it would those in this new system until such time as Medicare is brought in.
Yeah, that's a great point, Roger.
Yeah,
I didn't think about that either. That's the great thing about these meetings.
We're a big pool.
Well, there's a lot of brain power in this room.
I meant everybody we're going to be grabbing for this. This is not a small group of folks that are going to be covered.
Yeah. Okay, well, thank you for both of those comments. Going to these stakes in the ground, I can't remember where this first bullet came from. I think 1392 was floating out. Did 1392 pass?
Yeah.
And will that hold up under the new rules that are being proposed out of Congress?
Not likely.
Hey, you don't know yet.
I don't know. No. I don't know for sure, but there's a lot of concern about it.
Yeah. Yeah, the Republicans, going back on the Republicans in terms of their step downs, one is the work requirement deal we've heard before. Another great one that's going to hit Washington is for at least three states they singled out, us, California and whoever else, who provides immigrant health coverage. And again, this isn't through Medicaid, but they say if you're doing it, we're going to reduce your ACA rate from 90% to 80%. They're going to get sued on that. I don't think they can hold it, but they're going after that. And Liz, to your point on provider taxes, and what they're saying there, they're going to freeze them, number one, i.e. no newbies coming in, and they're not going to let you raise the effective tax rates. And that one may gain legs because it is leveraging. And Washington has done it big time. 47 states do it. So it's there now. So I think the bill's passed. It's going to have a rough hole, particularly if Congress does the actions it is in getting that 1392 implemented. And I see Pam smiling. She knows.
All right. Well, how about this? What if I word that bullet to say, since 1392 passed, if it's not prohibited on a federal level, that well, I don't even know what we do. I guess if we're doing additional analyses, we would take into account the fact that Medicaid is rising to Medicare, and then we would discuss, do we want Milliman to recalculate that normalized 125% with Medicaid at a higher starting point, contributing to that weighting? The second, I'll just go through these so you can react. The second being that we will, as instructed by the commission, should we be doing any future modeling, we'll incorporate the 200% cap. I will change my yes on the excluded populations to a maybe, maybe not, given Christine your comment and Roger your comment on the crowding out issue. I think this is where we should spend some time talking. Feel free to react to any of these, but I think this fourth bullet about whether we allow differential payments to continue for rural health centers, behavioral health care, et cetera. And the last bullet, what I'm proposing on the primary care side, the state has a multi-payer collaborative that has been in existence in one form or another for multiple years and is talking about the question of how to pay for primary care in the state, how to do it in a way that is standardized across carriers. I sit on that committee, and we have gotten to a point where the carriers have all agreed to a set of principles, but not to a standard methodology. And so my point being, I don't know that it's worth us spending a lot of time discussing how to pay for primary care exactly, given that work is out there and has plateaued to some extent, unless any of you have a model in mind, and would be happy to share it today. So before we get into that, Mary, why don't you go ahead?
Yeah, I just wanted to add one point about Senate Bill 5083. You mentioned that it has the 200% cap hospitals. It's a floor and it's a ceiling, because it's a ceiling for hospitals, but it also establishes the floor for primary care and behavioral health services as 150% of Medicare. So I don't know, David, if you meant to include that in your bullet, that we would, recommend following all of 5083, or if you're using 5083 just as the example of the 200%.
I can't say that I was thinking about it as thoroughly as you were, Mary. Okay. So I think the commission would say we want you to follow 5083, not just parts of it. And so
that's what they said. They really liked the idea of using these reference bases or reference points to be able to say, this is what we really want to be paying for. Like we want a system that's going to spend more on primary care and behavioral health and establish some floors for those things, because we think they're really underfunded in the way they are now. So they just said, take that modeling. We like that.
Okay.
And there may be other things in the future that they might want to change as well, but they liked this general concept of rebalancing dollars.
And Liz, does that basically solve the problem then of differential payments for primary care? Because 150% of Medicare for primary care is higher than what we've studied thus far at 125%.
Yes, I think so. It would just sort of be the reference point for the new system.
Okay.
But anyway, see you, Pam.
Yeah. Yeah, I thought on the 5083, that is only targeted towards the PEB/SEB population, because they're paying a very high rate on hospitalization. Medicaid is obviously not paying that, and neither is I don't think the exchange population, at least the Cascade Care population, is not paying that. So I think we've got to make sure that we're not encouraging paying a lot more for hospitalization by setting a reference point that's for this population that's way too high. So I think I just want to reconsider how we word that, or how you want to use that. I'm all in favor of reference pricing, but it shouldn't raise hospitalization costs.
Yeah, so Pam, just to restate, you're saying don't take our 125% in our Milliman modeling up to 200%.
Yeah. That's what I'm saying.
Yes. Okay.
Yes.
Got it.
Yes. And I think also, while I've got the floor a little bit, then the 1392, I agree with Roger. I would think there's some real vulnerability on the premium tax idea of, we have been leveraging, and so have 47 other states. And I think that I think we would need to look into that a little bit. I think the other things, there's going to be lawsuits back and forth. Who knows what's going to happen? But that one, I think there is some vulnerability.
Got it. Okay. Thank you, Pam. Roger?
Yeah. I would recommend, David, I think we talked about this notion about, we can embrace 5083. I think what would be helpful because there may be some further discussions with some of the commission members on this area of reimbursement. And maybe two things. One, sharing with them a chart that Milliman, we've seen this before, that Milliman put together that looked at what various programs are paying today as a percentage of Medicare. You know, it's showing that to them so they kind of have an understanding of what's being talked about.
Yep.
I think that would be very helpful. I strongly support the notion that we've talked about rebalancing. And, you know, we talk about primary care. I like the notion Liz mentioned about behavioral health. That's a critical area that's more under reimbursed actually than primary care. And the other ones that are referenced here somewhere in the discussions are areas about rural health and underserved areas. And let me just say this just a moment. Medicare and Medicaid have tried to speak to those issues through these concepts of federally qualified healthcare centers, which are more than just rural areas, but they're in rural areas, rural health clinics, critical access hospitals, these are small rural hospitals, and sole community providers. Those are all provider groups that are paid different than the underlying Medicare structure to try to promote access. So in our discussions, further discussions with them, I certainly like the idea of primary care, but expanding that definition again to behavioral health, I would put rural health and just underserved areas. Those are kind of a little bit hard to define. There's definitions around all those. That rebalancing occur to ensure access in those areas that have not the similar access that Bellevue, Washington has.
Yeah, I think that's well said, Roger. Does anybody, I agree with what Roger's saying. Does anybody disagree or want to voice a consideration? Okay, Eddie, did you want to chime in?
Oh, have my hand up?
No, it's just you came off mute, so I thought you were prepared.
No, well, I mean, we were listing a few of the items here. I mean, I was reading an article that was at the federal level, the cap on the ACA per cap. And I mean, those external factors, we're not really considering per se. But I mean, they're kind of out there hovering.
Yeah, you're saying if Congress acts to change the FMAP percentages or put a cap.
All sorts of, there's all sorts of, tails. And this one is a slight modifier where they're setting up a ceiling of how much it can grow. Beyond that, it becomes their savings or state's new share, essentially. And then it just continues to ratchet the FMAP. And so.
Yeah, I think that's a good point. So perhaps, I don't know if that goes in this section or in like an intro to just for me at the meeting to articulate, or for us to articulate the work group, that these things that are being discussed at a federal level will impact baseline cost estimates, future funding, et cetera. Yeah.
I mean, because now that we've done our analysis and these two bills pass and they significantly change what the work looks like, the 200% cap hospital inpatient, well, yeah, that throws a whole wrench in our data. So.
Okay, I got you. I'd like to reflect back to all of you what I'd like to change these bullets to based on the discussion, and give you time to state agreement or disagreement. So I'm thinking the first point is that in any future modeling, we would take 1392 into account unless it is prohibited from a federal standpoint. Somehow work in your point, Eddie, that there are other things happening at a federal level that affect everything we've talked about today. Pointing to 5083 and saying we're interpreting the commission's direction that both the floor and the ceiling would factor into any future analysis, and that in such a way that we're not raising overall reimbursement of the system to 200%. To to characterize the crowd out effect as equivocal, that there are reasons why you may or may not expect that to happen. To articulate support for the idea that behavioral health care, rural health centers, critical access hospitals, FQHCs, et cetera, and then primary care in general would, we do support the notion of disproportionately paying those organizations for the historical reasons why they were in effect, as well as for what 5083 does in providing that floor. So I don't know if that was easy to digest as I was saying it. Does that sound okay to all of you as me representing to the commission what we decided today?
David, this is one side piece. Is the folks that may not be familiar with 5083, it starts at 200 as a step down. Pam, is it next year or the year after to 190? So
Yes.
it has a step down. That's okay for this one, but just as a reference point for us.
Okay.
The year thereafter, the full implementation, I believe it is.
Yeah. Yeah.
Okay.
I think we have, some of our discussions with Bob and others about cost savings. I think as this group has supported reference pricing as a strategy, and I think Liz was saying ceiling and floor. I think maybe just putting it in terms of the concept rather than trying to get too specific about this bill, which is very targeted.
Yeah,
that's a great point.
And the concept of rebalancing.
Yeah.
And by rebalancing, that's where you're talking about paying certain provider entities more.
For certain services more,
yeah.
Yeah.
Okay. Okay. I think I just have one more slide, Keith. Do you mind going forward? Can't remember what's here. Oh, this was interesting, and Todd may talk about this. Somebody had asked about, as we get into cost containment, to just think about if reduced administrative burden on providers, so if we can reduce the administrative cost that gets baked into physician fees, does that actually mean you can lower provider reimbursement? Which I think is a fascinating question and something that would be interesting for us all to think about. I propose we think about that either in terms of Todd's presentation or at our next meeting. Folks were talking about just the interdependencies, which was a slide that I had presented that you may have all seen, that if, depending on the decisions that we make around benefits and services or provider reimbursement, for example, that either amplifies or de-intensifies the amount that we rely on unit cost controls. And I think this bottom bullet was just another recognition that we may not have additional funding. So that concludes what I want to get through. We have 1 minute before we're going to take a break. So Roger, I will give you the last word. Oh, Roger, maybe you could go 10 seconds, and Eddie, I'll give you 10 seconds.
Sure. On the one, this is an issue on administrative burden. Let me come at that a little differently. At some point, there's going to be a discussion about, and it ends up at this one, carriers or no carriers. In the work that, the work group did, A was with no carriers. They indicated a significant savings over with carriers. And the notion around that wasn't the administrative burden on individual providers. It was profit, et cetera, that was perceived to be from carriers.
Understood.
Okay. So at some point, I want to stay from that debate in particular, but at some point, and I think this is an area where we and others can be of help in this discussion on administration, and i.e. is going to fall around carriers, yes, no, state administered, yes, no, or the state purchased an ASO model to run this system.
Yep.
A lot of folks think there's significant savings in how that gets configured, absent anything that gets paid to providers directly.
Understood. Yeah. I think that'll be a good discussion to have. All right, Eddie, you get the last word.
This isn't just a procedure. I have to step away. I'm double booked to have a caseload forecast meeting to attend, so I have to head out.
Okay. Well, thanks for being here, Eddie.
Bye.
All right. Thanks, everybody. Let's take a 10-minute break and sign back in at 3:50. Mayor, I'm just going to wait 30 seconds.
You're doing a great job, David. Thank you.
Oh, thanks, Roger. Couldn't do it without you. Everybody, I appreciate everyone's input. It's been great. Team sport.
Team sport it is.
Okay. Well, welcome back, everybody. Thanks for a great discussion. Please remain in tab 5 of your packets. Todd from HCA is going to present on cost containment next, followed by an update from the cost board. So Todd, please take it away.
Thanks, David. Hello, everyone. Todd Bratton with the staff here at the Healthcare Authority. And today I am presenting an update on cost containment. And I also have an update from the Healthcare Cost Transparency Board. So after I go through those two updates, Ross Valori and I will make sure that FTAC can comment on the cost containment approach going forward. And Liz will help wrap up the day by facilitating FTAC discussion.
Hey, Todd, hold on a second. I see Mary's hand. I don't know, Mary, are you intending to interrupt?
Nope, that was an accident. Sorry about that. I'll put it down.
No problem. All right. Sorry, Todd.
Keep going, Todd.
Okay. So starting here, looking at the work plan, just to get us reoriented to that. And if we look at the key design elements on the right, you see that cost containment is listed as its own element. And so when we began the cost containment studies in late of 24, we began by looking at reference-based pricing and through the FTAC's work and the commission's work. And when the commission asked FTAC to help identify other cost containment strategies, we started by looking at the entire universe of cost containment in healthcare. And through several emails and drafts of a memo, FTAC was able to review and organize a whole universe of cost containment strategies. At that point, the interdependencies that David has talked about became really clear with reference to cost containment. And we see that cost containment mechanisms are not this isolated design topic, but actually a unique component to be addressed within each of the other key design elements. And so that's what the Commission and FTAC are already doing, collaborating on cost containment much faster than a memo can communicate. Some of that work was done just earlier in this meeting. And so that is the approach that the HCA staff here are suggesting continues with FTAC and the Commission consensus to continue to call out cost containment efforts within this design work related to benefits and services, for example, or provider reimbursement or other of these design elements. So with respect to provider reimbursement, FTAC has reviewed hospital global budgets, reference-based pricing, and like I said, a whole host of other strategies identified in various reports from the Office of the Insurance Commissioner, the Attorney General's Office, and elsewhere. And so there have been actually some pretty good recommendations that have come out about reference-based pricing from those discussions. So the strategy as we are, or the approach as we are presenting it would be over the next two meetings for the focus really to be, what do these strategies around reimbursement and cost containment say about what we want to do in a universal system? Do we want to establish certain levels to set out based on reference-based pricing, enhanced rates for services? Some of the questions that David was just getting at. And so potentially referencing the mechanisms over the next few meetings within that discussion on provider reimbursement, but not necessarily doing a deep study of each of these mechanisms. And so that strategy can continue into the future, that approach to cost containment as you go through the work plan. There will be agency report outs in the meetings, cost board information being reported, and the Commission and FTAC can continue to address cost containment within the design. For example, the infrastructure discussion is coming up in the work plan next year. And there are many of the strategies that you reviewed that fall into infrastructure and administrative categories. I'm not so sure about governance. It would be interesting to think if there are any cost containment strategies related to governance. But so far, I don't think I've identified any. So before we get to a discussion on that approach of just reviewing cost containment and noting how FTAC and the Commission are utilizing cost containment within their discussion, we wanted to discuss real briefly an update from the cost board, because we feel that will also inform your decision and your discussion. So real briefly, I'm going to transition into a discussion on the cost board now. So to orient our discussion about why the cost board's work is important to the Commission, this is the Commission's directive in part from the legislature. And the Commission has asked for some of these things in these bullets, and you can see those are really directly related to what ended up in the work plan: benefits and services, provider reimbursements. And they've taken, the legislature has really asked for strategies that are designed to help the state meet its healthcare cost growth benchmark. They've also tuned you into effective provider payments and global budgets. So interested in those sort of things. So that is really how the Commission, FTAC, and the cost board are connected. So the following sources were presented to the cost board at their April 24th meeting. And the presenters were Michael Baylett, a cost board consultant, and Harrison Fontaine here from the Healthcare Authority staff. And you can access the full meeting materials at that link. I am going to do a brief review because Michael Baylett and Harrison Fontaine are experts, but I believe Harrison is here to answer some questions after the fact if there are some more in-depth questions. So this is the material from the cost board, and this is generally describing their directives. Identify trends in healthcare cost growth, analyze total healthcare cost expenditures. Now, those two boxes on the left are really what has taken a lot of the focus of the Healthcare Cost Transparency Board's work over its initial first couple of years of work, looking at the data, looking at attribution, and setting the benchmark. At this time, the cost board is moving more into looking at policy recommendations. That is another charge that the legislature has requested of the board. So in their presentation and looking at these benchmark programs, Michael Baylett presented this information to them really early on in their work and represented it in this presentation, that cost growth benchmarks do not result in meaningful actions, and they are meant to serve as a catalyst for other affordability policy actions. So like I just mentioned, you can see that the cost board has been really in the analyze and report and measure work and working on those buckets there. And now they are moving into more of identifying opportunities and strategies to slow cost growth. So getting into a little bit more of how cost growth benchmarks do not sufficiently address hospital price growth, that is the topic that the cost board has decided to look at first, is hospital prices. So cost growth benchmarks do not hold hospitals accountable for their specific contributions to the spending growth. And so just measuring the expenditures does not fully address price and utilization. So why focus on hospital spending? They looked at some of the data, and hospital prices being the #1 driver of commercial market spending in the US. Additionally, from some of the state data and the data calls that put out by the cost board, hospital outpatient services were one of the largest contributors to cost growth. Additionally, prescription drugs were also a contributor to price growth. However, the Prescription Drug Affordability Board is really focused on that work. And so that's why the cost board chose to look at hospital prices. So here's a little more context about hospital price in Washington State. And then these are some of the strategies. I'm not going to go into these in too much, but these are the potential strategies provided to the cost board to investigate on addressing these issues. And one of the ideas that cost board members seem to be interested in is the idea of hospital global budgets and how to investigate that further. So that was a really quick overview of the cost board just starting to step into this issue of policy levers. And this is some work the Commission and FTAC have been involved in for some time. But we wanted to cue you into the fact that the cost board has tuned its attention to this work. And hopefully that can inform your discussion about what should be addressed with FTAC and what is better with the cost board. They are going to be diving into this work in detail. And so moving forward, what should be their responsibility and what should FTAC continue to look at? So with that being said, I just want to clarify whether FTAC members are okay with the approach of going forward of really noting how cost containment can be utilized within each of these other benefit design elements, and also tuning into the cost board and other sources to identify potential transitional solutions. So over the next couple meetings, when FTAC is looking at provider reimbursement on the agenda within the work plan, we can also bring a list of those cost containment strategies that were specific to provider reimbursement, and FTAC members can say whether this speaks to how the system should be designed, or whether some of these are transitional solutions that need investigated further. So I hope that approach seems pretty straightforward, and Ross and I are available to take feedback on that at this time.
In just one minor note, I'll add from the cost board perspective, we do intend to have potentially multiple policy levers running in tandem. Our goal is we have limited resources and time and want to focus our efforts efficiently. But that's not to say on the cost board side that, if we select one, we will not pursue others. But we need to understand, that they're complementary and that they work with one another. But just to identify that, we hope to utilize several of the cost containment mechanisms as a way of kind of addressing current healthcare costs. In that aligns with the Universal Commission's focus on key design elements with cost containment. And we're really looking forward to highlighting some of the work that the Commission's been doing, and really excited that Bob Murray is willing to present at our June 3rd meeting on hospital global budgets as one of those types of policy levers. So that's a goal of ours over this next year, is to continue to try and integrate some of the work, the cost containment work of the cost board with some of the great activity that's being done related to cost containment and universal design here with the Commission. So thank you. Happy to take any questions.
Ross, can you clarify that, hi everybody, that Bob is going to be talking at the Commission meeting, or is it at the cost board meeting? Okay.
The cost board, yes.
Okay.
The June 3rd Healthcare Cost Transparency Board meeting. I don't think we typically use chat here, so maybe I can work with Mary to circulate a gov delivery just with that notice so that folks have it. But so we are hoping to, as the cost board is working through those different, what we're referring to as policy levers, cost containment mechanisms, educating them on the ones that they had identified as of special interest. And hospital global budgets wasn't actually listed, but several cost board members thought that was a great solution. And, we knew the great work Bob has been doing, so thought it would be a great opportunity to bring him to present on that.
Well, and I think given the conversations that have happened at the Commission, particularly around the one about rural hospitals and the impact of different, policies on rural communities, and the fact that the new legislation has this special exemption for rural communities. I think that the hospital global budget conversation will be very timely because folks are wanting to know, well, what can we do about other parts of the system? So,
excellent point.
Great.
Yes, that's excellent point.
So-
And happy to take any questions. If there aren't any questions, I just want to brag about Todd just for one moment now. Todd has been such a pleasure to work with. It's so sad that he's going to be leaving us, but just thinking about, I mean, you've seen much of Todd's work, but I think one of the things that speaks loudest about Todd is, as we've been learning and finding that this position will be ending, Todd's work and effort has not decreased one bit. It's maybe increased. And, I put myself in those shoes and I wonder if I would have the ability to do that. It's just incredibly impressive and shows Todd's just true commitment to this work and interest and advocacy, and just couldn't be prouder to work with Todd. And just thank you so much for all your work. We really appreciate you. I'm really sad to see you go. Thank you, Todd.
Thank you so much, Ross. This has been really interesting to me. I decided to try to get back into public service. And when I got the opportunity to work on an issue that I've been really interested in since grad school and working with the Indian tribes, getting to work with the commission and FTAC members on these issues is really rewarding. So it's going to be sad to go, but I can guarantee you I have some other really good opportunities. So I will miss you all and hope to pay attention to the progress you make in the future. Thank you.
Thank you, Todd. Oh, Roger, please go ahead.
So, Ross, what do you help me? What are you asking of FTAC at the moment?
So I think the main piece that we're trying to get clarity on right now is if FTAC is in agreement with this way of reviewing cost containment, where cost containment would kind of be reviewed as part of each of the key design elements, as opposed to a separate key design element that's pulled out and analyzed separately. And part of that thinking is, understanding the cost board's current work, and kind of as more information comes in, and as we study more about these policy levers, that information could be helpful further down the road to the Universal Commission and FTAC as they're considering these design elements. So just an opportunity to kind of bring cost containment along. Todd, please clarify if I misstated anything there.
Well, it's sort of a realization that the work is being done. The cost containment work is actually being done within your discussions and through the meetings. And so there are all these strategies out there that address different pieces of the work. And so do they speak to how the system should be designed, or do they speak to transitional solutions? And if not, that maybe they can be ignored for now, or they're in the purview of the cost board. So just hoping to focus the work and acknowledge that cost containment is not an isolated subject.
Right, okay. Because let me try a couple of shots and I'll shut up. I mean, we've always drawn the distinction between, cost containment is something we do now, or the new system, whatever the new system is. Of course, my response is, well, if these are good endeavors, we want to embrace them as soon as possible. We're living in the real world we are, and if these strategies, let's just try global budgeting, hospital global budgeting, if it should work. I mean, it seems to me it's somewhat of a foregone conclusion that would be a consideration in the new system. So my point is that sometimes we're going, is this something that should be part of the current system, world, or the future? And to me, part of the strain has been twofold. One is from the commission's perspective. I'll try this again. FTAC can kind of come up and say, well, here's a laundry list of good ideas. And commission, here they are. And these are transitional solutions. And kind of the response back is, so what are we going to do about it? And I'll try it again, it can't just sit in a report. So that's my little pontification. My struggle has been in this area is that the Healthcare Cost Transparency Board, to a degree, was created before the commission to do cost containment work, right? And relatively speaking, I know the board may not feel like they're resource rich, but they have a lot more resources, analytic resources, than the commission does, and certainly more than FTAC does. So we might say, well, this is kind of a nice idea, but my point is, mine is we don't have the resources to do that analysis. And the best that I feel like we have available at times is certainly share maybe some of those ideas with the commission, maybe the meritorious or not. But if we're talking about transitional solutions, we ought to be working hand in glove with the Transparency Board. And quite frankly, they ought to be guiding our work, right? I mean, that's their that's their number one charge. I
completely agree, Roger.
Yeah, so
that's kind of
okay. Sorry.
That was our thinking, is a way to, in looking at RCW 4105847B6, that kind of talks about cost containment, and the way that it's referred to does seem to indicate that the Universal Commission and FTAC aren't necessarily coming up with the cost containment strategies, but sort of building off the work of the cost board and other entities and then incorporating those strategies in its universal design. I think similar to what you're talking about, Roger. And I totally agree that the cost board is very focused on those cost containment strategies, and the commission has a lot of other work related to universal design. So we can, to your point, hopefully work with one another to kind of build out those cost containment strategies and better utilize Universal Commission's time. Pam, go ahead.
Yeah, hi. First of all, my quick thank you to Todd and wishing him well, and happy to hear there's some opportunities out there for him. Well deserved. So Ross, thank you for your presentation, and Roger, thank you for getting the clarification. We've been talking about cost containment from the beginning, and I think on two levels. One is looking at transitional solutions, what should we do now? And also thinking about what would be in a universal system. And we've had a real advantage in having Bob on our group. So, he's done presentations to us. So we've spent a lot of time on reference pricing and global budgeting as well as other ideas, and also hearing what other states have tried and what seems to have worked well and not as well. So I think we're really well positioned to have more of this dialogue. I'm very excited that I'm hearing from you is that there's going to be more permeability between the two groups, which I think would be really to the benefit of both of us. I think we would get a lot out of hearing more directly, getting more direction. But I think our group has been pretty assertive on the cost containment. And we actually did a formal recommendation, I think, back to the commission that they should endorse reference pricing. I think every chance we've gotten, we've tried to kind of go through there. One of the things that I think is really important is that if we want to do more with our system, it needs to be cheaper. It needs to be more affordable. So we want to cover more people have more benefits, all the aspirations that we have and that we hear from the advocates at every one of our meetings. We have to have a more affordable system to realize that vision. So that's where I think we can really connect with the commission.
I completely agree. And I think Todd began the presentation with kind of the three blocks that the cost board directives that the cost board is working under. And much of the cost board's work, the majority, is really understanding total healthcare expenditures and seeing how much hospitals and healthcare entities are spending, to your point about cost growth, and then looking at these, what we're referring to as policy levers, cost containment mechanisms, as a way to really take that next step and really hold entities accountable. But yes, would love to continue working, especially with this group on cost containment strategies and mechanisms, and continuing to kind of build that permeability. I love that, Pam, between the two.
Yeah, thanks.
Thank you. David, please go ahead.
Well, I appreciate everyone's comments, I want to share how this is forming up in my mind and see if you think I'm off track or if it emphasizes, Pam, what you said and what others have said. The logical steps that make sense to me are we start with who we're going to cover, what benefits we're going to allow, and that's where we built up our benefits and services option. And with the Milliman study, we got estimates of the billions of dollars that are involved in moving from one scenario to another. And then I think to your point, Pam, the idea is, well, it's tough for the state to add $2 billion in cost or X billion in cost to the system. And so we all need to be talking about bringing that cost down. And I think that's the purview of the Transparency Board, the cost board. And it feels duplicative for us to have extensive conversations about what are the right cost containment strategies, because that's the purview of the board. Although, Pam, I like your point that there might be specific strategies that we latch onto and advocate for. I'm just saying I don't know that we need to spend a lot of time debating global budgets versus elimination of facility-based fees or any of the other strategies out there. It does seem where the question comes back to us is when we get into the conversation around administration, and is there, to Roger's point, is there cost savings between Model A and Model B? I'm assuming the cost board is not dealing with that question, and that will fall primarily to us. So I think I'm on the same page with what you said, Pam, what you said, Roger, with maybe one distinction being, I don't know how much we need to debate specific cost saving strategies here, but pay attention to what the cost board is figuring out and pushing, and then we weigh in on that.
Ross, another thing would be helpful, for jumping in on that. Also, just from your perspective, not only the cost board, but likewise what the healthcare authority is thinking about. I always give a great example because I love to throw it out there. Is I'm a great believer in competitive selective contracting. I answered this one before as an example, and I think it does work. My point being is, well, are those some items that are under consideration today by the healthcare authority or not? So I think what would help us both as we think in the future, and maybe that way, likewise with the cost transparency board, is getting feedback from the healthcare authority itself. Your expertise, what directionality you're thinking about.
And is that specific to cost containment mechanisms, Roger?
Yes, it is.
Okay. Yeah. And I think a really good example of that, which Todd covered, is 5083, the PEBSEB reference-based pricing bill, which is, an agency proposed piece of legislation with a cost containment mechanism. But you could see how that could translate to the cost board's work and some of the commission's work. So yeah, I think that's a really great example, and I'll continue to look for ways to highlight the agency's perspective related to these specific cost containment mechanisms as a way of kind of informing both the Universal Commission and NEPTAC.
Yeah, and then we clarify not only their feedback to whatever we're thinking about, but likewise what they're thinking about.
What the cost? Yes.
Yeah.
Ross, so I should have. Sorry, Todd. One follow-on comment. I should have asked my comment as a question rather than a comment. Is the distinction that I'm drawing, and I guess the tentative conclusion I'm coming to, is that consistent with what you and Roger and Pam and others have been saying, or is that discordant with what you're thinking?
Who is the question to, David? I apologize.
Well, I guess that's to you, Ross, with an invitation to Roger and Pam and anybody else to chime in.
I agree with that interpretation. I think we were chatting about this several weeks ago in preparation for these meetings, and we were reviewing the statute. And when you look at the statute and the instruction related to how cost containment is talked about in the legislative report, it indicates more of an update rather than original work being done by the commission, because there is a ton of original work being done. And so kind of based upon that understanding and the charge of the cost board to look at and make recommendations regarding cost containment mechanisms, we reached that same conclusion, David, that it seems better served for the Universal Commission to be focused on these universal design elements and incorporating information from the cost board who's actively researching this, and then building on that, rather than spending time doing original research on these concepts that would be duplicated at the cost board. So I think there's support for that in the statute, as well as just kind of just being efficient with resources.
Okay, and Pam, is that consistent with what you were thinking?
Yeah, it is. I think that, for one thing, I think we've already had a lot of discussion about cost saving strategies, that it would almost be kind of going over new ground. And in those discussions, we were doing more of a assessment of what's available. We weren't, going back and recreating new work or new approaches. I think we were just learning the landscape and what's applicable to short-term versus long-term, what's applicable to looking at how we kind of bring down costs before we implement major changes. So I think it's more, I'm not coming up with the right words, but it's more, it's kind of a tool for us to use, but it's the commission, it's the Healthcare Cost Transparency Board that comes up with those tools. And we think about how to apply them to the recommendations that we're making, because we are the finance technical committee. So these are things we need to use. And I think that the more open communication will really help us make sure that we're not duplicating efforts, and we're able to fully utilize the work that the board is doing. So
that's great.
I do agree with you. And I also want to acknowledge the work we've already done that has created a nice foundation for how we think about these things.
Excellent.
And David, I agree also. And just back to this point about resources, we're again in a situation where we're going to be more stressed with resources this coming biennium than we were last. And I know Ross really appreciates that. And such to the point is that, if we were asked to look at something, I would think that the commission, they would say, well, you need to go out and do some analysis on this. And as we've seen before, say, that's fine. Well, we need, dollars to go out and get some consultants to do some work for us, because not that we don't have the expertise, but we're not structured to do that analysis ourselves. And as we don't know, we don't have the resource base to do that now. And all I'm trying to say around this is it really begs even more the issue about this closer collaboration that Pam has been talking about, and how essential that's going to be, especially given the resource constraints we have. One other thing I would add, I think it was a good one, Todd, back to everybody. One of the challenges I think we all face is there are cost containment designs. And let me just use global budgeting, because we've talked that before. And I remember we had a conversation. Hopefully Bob's still on the phone. I'm sorry, still in the meeting. And it was either Todd or Mary asked Bob a question about that. And Bob kind of said, I'm paraphrasing, well, if you give me a system design, you know what the new system is, I can talk about ways that global budgeting can, impact that new system. But we don't have the new system and design yet. So I can't really give to you, robust detail about that yet, because I don't know what the system is. Versus, we are in a given environment now, and Bob's going to be talking, to the board with potential model to consider, and you have enough structured analysis there to do the analysis needed to look at that viability. I'm sorry, I'm wandering here too much again, but I think you hear the gist of what I'm trying to say.
No, I really appreciate that, Roger. And another piece that I'm really excited about is hopefully the cost board's decision is informed by the data that we've been reviewing. We've been doing cost driver analysis at the cost board, in addition to the data call cost growth against the benchmark. So hopefully any policy lever that's chosen is supported by current data regarding the Washington healthcare market. And we can also bring that to kind of contextualize the policy lever that we're discussing, which I think is not the types of information that the commission is normally looking at, just to give a slightly different perspective, speaking to more the current landscape. So I think that can be really helpful and interesting. And I'm sorry, Bob, please go ahead.
Well, no, it's okay. Roger, I wasn't exactly sure said you were paraphrasing what I said. My approach is I don't really care what the system looks like. And the universal system or whatever. I'm starting from the premise that costs are far too high. And regardless of the strategy that Washington adopts, the state needs to focus in on cost containment, regulated cost containment strategies. So anyway, just to clarify, I don't care what the system looks like. We're in a situation now where costs should be the number one priority, controlling costs. Whether it's a universal system down the road, I have my doubts about whether universal systems are feasible to implement. But regardless, the state needs to focus on constraining costs. And that's kind of been my mantra all the way through this. Now, we talked a little bit about this, but I would advocate that the FTAC or the state, or maybe the group of us get together and outline an actual cost containment strategy with phases and just kind of a comprehensive cost containment strategy, and the cause and effect and the various models that could be or should be implemented, and then a time frame for implementation, and then also talk about governance and how this all would come to fruition. There's a political element to it as well. So all those things should be factored into a cost containment strategy of some sort. But thus far, nobody's really kind of focused in on creating a strategy. We've just kind of generally talked about the need for cost containment, which is urgent. But I would advocate that we kind of get into more detail about how this would unfold. But those are just kind of general comments.
Thanks, Bob. Ross, I think I'm going to bring us home. Did you want to say anything else before we?
No, just want to make sure. It sounds like everyone was comfortable with that approach of integrating cost containment into the key element design or the key design benefits. Just wanting to make sure that was accurate. I believe so. So I'm not hearing any pushback. Yes, that's fantastic. Just want to make sure we addressed any questions. And please feel free if you have additional questions on this. If you email, happy to respond in writing as well. Thank you for the time. And Todd, thank you so much for all your work.
Great. Thank you, Todd. Thank you, Ross. Todd, do you want to say something before?
Oh, just thanks, y'all. I think I already said it. So thank you all.
All right. Liz, do you want to chime in with anything before I close this out?
No, it's been great conversation as usual. Thank you.
Okay. Well, thank you all for a productive meeting. As you know, I'll share the highlights of our discussion with the commission at their June meeting. Our next FTAC meeting will be on Zoom Thursday, July 17th at 2 p.m. And we are adjourned at 4:28 p.m. today.
Thanks so much, everyone.
Thank you.
Bye-bye.